Thanks everybody for joining. I'm Dr. Benjamin Cohen. I'm the co-section head for IBD at the Cleveland Clinic, and we're really excited again to have everybody for our second part of this patient and provider perspectives series. And today we're going to talk about how to monitor your disease for long-term remission. So we want to thank over 515 patients and healthcare providers who've registered for today's event from across the globe, including 40 countries. And we want to encourage you to interact during the program via the chat box. So we want to make this as interactive as possible. I encourage you to include your questions in the chat box. We'll try and incorporate those into the cases to get the inputs from our expert panel. And you can put any comments in there as well, and we'll try and address them. We want to thank our corporate sponsors for their generosity in supporting the series. We wouldn't be able to hold these educational offerings without their support. So we thank AbbVie, Janssen Biotech, and Takeda Pharmaceuticals America for their support tonight. And I think I'm most excited for the amazing panel that we're going to have when we get to the portion of the session where we go through the cases. So we have my colleague, Dr. Florian Rieder, who is the vice chair in gastroenterology, the co-section head for IBD, along with me, as well as our director for our program in global translational IBD, which is a new program at Cleveland Clinic that we're really excited about. We also have my colleague, Dr. Maliha Nasir, who's an associate staff, an advanced IBD expert that's going to provide us with her thoughts. And really one of the highlights of this whole series is that it's not just about the healthcare practitioners, it's about the patients, because we know that much of IBD care now is about shared decision-making and how we work together to find the right treatment for patients. So we're excited to have Aswani-Omprakash, who is an amazing patient advocate, and we're going to hear more about her story as well. And then our advanced IBD fellow, Dr. Mohammad Alomari, prepared our cases for tonight. So thank you, Dr. Alomari. And so the flow for tonight is that I'm going to start with a talk about how to monitor your disease for long-term remission. Then we'll hear from Tina about her patient journey, and then we'll go into some cases so we can really talk about how we implement disease monitoring for patients. So again, I'm excited to talk to you today about how we monitor disease for the long-term remission. And I'm going to pay really some special attention to recent updates on biomarkers from the AGA guidelines that were recently published. Here are my disclosures. So our objectives for today are that we want to delve deeper into IBD monitoring by really defining what biomarkers are and describe how we can use them to monitor disease in clinical care. We're going to review the role of endoscopy, and then we're going to try and implement these monitoring tools into a treat-to-target approach. My hope is that this provides a roadmap that both clinicians and patients can follow so that we can keep IBD in remission. And I like to think of IBD management as a long road trip. While our ultimate destination is remission, there's a lot of monitoring steps that are needed to get us there and then to keep us there. So it's really much more about the journey. So our discussions of monitoring are going to be framed by the concept of treat to target. So what is this for everybody in the audience? The premise of treat to target is that a failure to treat chronic disease promptly and effectively can result in serious complications and disability. So by treating to predefined targets associated with desired long-term outcomes, we can avoid disease-related complications. And in order to achieve the targets, it requires a strategy of ongoing and regular monitoring with treatment optimization when the targets aren't reached. And really critical to the strategy is that we have to predefine the targets in collaboration with patients and map out a plan of how we're going to get there. Treat to target has effectively been used in diabetes, hypertension, rheumatoid arthritis, and now there's significant momentum in IBD. Treat to target's relevant in IBD because we have increasing evidence that shows us that early disease control can help prevent long-term complications of Crohn's disease, such as strictures, fistulas, abscesses, and potentially delay or prevent the need for surgery, which you see in the graph on the right. And if we implement a monitoring strategy, we can control disease in that early window of opportunity, which is shaded on the left, and hopefully change the disease course to the graph you see on the right. And this is also likely relevant to preventing bowel damage related to ulcerative colitis as well. So you may ask yourself, why can't we just rely on symptoms to tell us when we have to adjust therapy rather than have to do all of this monitoring? And the reason is that symptoms don't correlate well with disease activity. This is an old study showing that symptoms calculated from the Crohn's Disease Activity Index, or CDAI, don't match up with the blood inflammatory marker C-reactive protein. So in the top left quadrant, you see a significant number of patients have low symptom scores with high inflammatory markers, representing a group who's probably undertreated. And this reinforces the need to have objective assessments of inflammation to help guide our management. Now, the tools available to monitor disease activity in IBD continue to evolve. So in the past, on the left, we were limited to clinical symptoms, endoscopy, and imaging on an as-needed basis. And now in the middle, you see we incorporate objective markers along with symptoms in a treat-to-target strategy. We phenotype patients to select therapies and monitor response. There's also increasing uptake of point-of-care non-invasive monitoring, such as ultrasound. And in the future, on the right, we'll likely evolve further by incorporating imaging-based targets into our outcomes, utilize novel imaging techniques such as elastography, motility, and diffusion-weighted imaging, as well as incorporate artificial intelligence-based approaches. So what is a biomarker? A biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological response to an intervention. And while endoscopy is the gold standard assessment for determining if we've reached the target of mucosal healing, it's expensive, invasive, and not always wanted by patients. And biomarkers represent a potential surrogate assessment for mucosal healing. Now, the ideal characteristics of a useful biomarker include being non-invasive, convenient, rapid, inexpensive, reproducible, specific to IBD, precise, and having defined thresholds, and ultimately being validated. And from diagnosis through treatment and even possible surgery, there are numerous opportunities to utilize biomarkers in monitoring. So biomarkers, and you see in the green boxes, can be used to measure response to therapy, monitor relapse after a medically induced remission, or even monitor for post-op recurrence in the case of patients who have surgery. And there have been meta-analyses of biomarkers correlation with endoscopy that have shown that both C-reactive protein and calprotectin can be beneficial, but fecal calprotectin is more sensitive, particularly in ulcerative colitis. And fecal lactoferrin is also another biomarker that has strong characteristics, but it's less commonly used in clinical practice, in part because it's most often reported as present or absent, and it doesn't give you a quantitative value. Now, evidence supporting a tight control approach using biomarkers comes from the CALM trial. And briefly, 244 early diagnosed Crohn's disease patients who had never been treated with immunomodulators and biologics were included. And they were all on the biologic drug adalimumab and randomized into two arms. So patients who were in the conventional management arm, seen in the green on the top, were dose escalated based on clinical symptoms alone, whereas patients in the tight control arm, seen in blue on the bottom, had their therapy escalated based on both clinical symptoms and inflammation biomarkers, specifically fecal calprotectin and C-reactive protein. And importantly, these were all patients who were early in their disease with a median time from diagnosis of 0.2 years. And the primary outcome of the CALM trial was endoscopic remission, which was defined based on the endoscopic score CDEIS, which is the Crohn's Disease Endoscopic Index of Severity, and having no deep ulcerations, with secondary outcomes that included a deep remission, biologic remission, and mucosal healing. And what you see here is that treat to target utilizing biomarkers and symptoms was associated with significantly higher rates of achieving these outcomes as compared to using just symptoms alone. So with the increased attention on disease monitoring, the American Gastroenterological Association has released new guidance on the role of biomarkers for both ulcerative colitis and Crohn's disease in the last year, which can give us a more practical guide of how to apply these in our clinical practice. So I think the important take-home points from the new AGA guideline recommendations are the following. One, the AGA suggests a monitoring strategy that combines both lab biomarkers, so C-reactive protein, fecal calprotectin, and fecal lactoferrin, as well as symptoms for both ulcerative colitis and Crohn's disease. The relevant calprotectin cutoff for both ulcerative colitis and Crohn's disease is 150 micrograms per gram, regardless of which assay is used. And this is important for patients to understand, as some assays will read abnormal with even lower values of calprotectin, despite your physician saying that it's normal. And in postoperative Crohn's disease, a cutoff of 50 micrograms per gram should be used within the first year after surgery, and I'll talk a little bit more about that. Endoscopy is still a critical component of IBD monitoring, and the guidelines don't make any specific recommendations in favor of or against a biomarker-based strategy over instead using an endoscopy-based monitoring strategy. And four, it's important that we benchmark these lab biomarkers against endoscopic or imaging disease activity at diagnosis or prior to treatment. And I'm going to talk a little bit about what this concept of benchmarking is. So the reason benchmarking is important is that there are exceptions to rules. C-reactive protein may not be elevated in up to 20% of patients with inflammation, and it's also not specific to IBD. Fecal calprotectin can also have variations. So therefore, we want to know the value of these biomarkers when we have confirmed inflammation by endoscopy or imaging to better understand how to interpret changes when we monitor them over time. And ideally, we should try to use the same assay for repeated measurements over time in an individual patient. And this is really why you see some of your physicians, for the patients out there, harp on getting your stool testing in around the time that you do the colonoscopy. It's because we want to know what that correlation of the biomarker to your scope is. And while sensitivity of calprotectin is pretty good, there are a number of potential causes for false positive tests, which can include polyps or neoplasia, infections, medications such as nonsteroidal anti-inflammatory drugs, and obesity, among other things. So again, just highlighting the importance of knowing what your baseline fecal calprotectin is against the endoscopy. So another area I think worth highlighting from the recent guidelines is when we can use lab biomarkers as a potential test replacement strategy for endoscopy. And this is important because we may not be able to get a timely endoscopy. Patients often prefer not to have an invasive test if they can do something else. There could be cost considerations for the patient. So in asymptomatic ulcerative colitis and Crohn's disease patients who have normal lab biomarkers, who have been on a stable treatment, we can defer colonoscopy if the patient has previously been confirmed to be in an endoscopic remission on that treatment in the last 3 years. And in this case, we would recommend monitoring the biomarkers every 6 to 12 months while the patient is asymptomatic. In ulcerative colitis patients who have severe symptoms and elevated biomarkers, you may consider doing a treatment adjustment without an endoscopic assessment. However, I think an important point is that shared decision-making is always important for this scenario, and it's entirely possible that patients may want confirmation about their disease activity before they make a change in their treatment, and similarly, the physician may want confirmation. Thirdly, when patients have had a recent treatment adjustment with improving symptoms but still have some elevated biomarkers, you can make treatment adjustments based on the biomarkers without necessarily needing to repeat the endoscopy right away. And I think, lastly, a new concept is that in Crohn's disease patients who've had a recent small bowel resection, those who are low risk for disease recurrence by risk factors, or who have started on an advanced therapy postoperatively as prophylaxis against recurrence, can potentially defer their colonoscopy in the first year after surgery if their fecal calprotectin is less than 50. So this is a change from the prior recommendation that all patients require colonoscopy in the first year after surgery to assess for disease recurrence. However, if the calprotectin is elevated or patients desire a higher degree of confirmation about their disease activity, patients should still have a colonoscopy. And I would add that patients with multiple prior surgeries or those who have been on multiple advanced therapies and not responded may be among those who would reasonably still choose to do an early colonoscopy because these are people with a more severe disease course. And I think the last important point is that CRP is actually not recommended as a biomarker to follow in the first year after surgery because it doesn't correlate well with inflammation. With all these recommendations, when symptoms and biomarkers are discordant, endoscopy should still be performed to assess disease activity. And importantly, biomarkers don't replace the role of endoscopy for other indications. So these may include dysplasia surveillance, ruling out infections such as cytomegalovirus, and also undergoing endoscopic treatment of strictures. So in the course of creating these guidelines, a number of biomarker knowledge gaps were also identified. We still have a lot to learn about the timing of measuring biomarkers, including the best time to check after treatment changes. While the CALM trial has set the standard for treat-to-target studies, we need a similar study in ulcerative colitis. Additionally, we need studies that compare different cut points of biomarkers, combinations of biomarkers, as well as establishing the role in asymptomatic patients. And importantly, there are no comparisons of biomarker-based strategies and endoscopy-based strategies. The guidelines focused on the performance of biomarkers in detecting inflammation. However, data is lacking to examine the prognostic significance of the magnitude of elevation, as well as having persistent elevation over time. So for example, if a fecal calprotectin is 3,000, we don't know what that means relative to, say, a fecal calprotectin of 300. Biomarker performance also needs to be better studied in diverse populations, such as patients with mild disease, patients with J pouches, and patients with different distributions of Crohn's disease. So somebody who has ileal Crohn's disease versus somebody who has ileal and colonic disease. Importantly, we need to understand better how the lab biomarkers compare against other imaging-based disease activity assessment modalities, such as CT, MRI, and ultrasound. And our hope is that with further recognition of the importance of biomarkers, that we'll begin to close these knowledge gaps and further improve care. So while I just said that the timing of making assessments after starting new treatments is a knowledge gap, there is still some guidance on this from the International Organization of IBD. The timing from this expert consensus depends somewhat on the medication that's used and the expected speed of onset of the medication. So with anti-tumor necrosis factor medications, the timing of biomarker improvement is expected in the 1 to 3 month range, with endoscopic healing occurring in the 4 to 6 month range. And then for vedolizumab, normalization of biomarkers takes a little bit longer in the 3 to 4 month range, and endoscopic healing around 6 months. And finally, ustekinumab biomarker normalization occurs around 2 to 4 months, with endoscopic healing in the 4 to 6 month range for Crohn's disease. And these recommendations were published prior to the approval of upadacitinib and risankizumab, which is why you don't see them. But I would expect similar timing to anti-TNF and ustekinumab for both. And I think it's important to have a general idea of these when patients and physicians are talking, so you can set sort of the map for when you're going to do these assessments to check your response to therapy and set expectations. In ulcerative colitis, biomarker response is typically seen at 10 to 12 weeks with anti-TNF and tofacitinib. Similar, upadacitinib would be similar. And again, response may take a little bit longer with vedolizumab at 14 to 15 weeks. Now, while there's a clear utility for serum and stool-based biomarkers, patient surveys have actually shown increased acceptability of imaging-based monitoring, particularly ultrasound, relative to doing stool-based biomarkers as well as endoscopy. And cross-sectional imaging plays a number of roles in disease monitoring. So prior to treatment, it's critical for staging disease by identifying intestinal and extraluminal lesions, assessing for disease activity, and also identifying for stricturing disease in the case of Crohn's. During treatment, it can have a role in assessing therapeutic response as well as predicting treatment outcomes. And similar to the biomarkers we've discussed, imaging is also important for identifying postoperative Crohn's disease recurrence. There are advantages to the various imaging modalities where you may prioritize them for some clinical scenarios. So regular CT scan may be favorable in the acute setting, and CT enterography may be preferred over MR enterography in terms of the turnaround time and fast image acquisition when patients can't tolerate an MRI for reasons such as claustrophobia. MR enterography has the benefit of no radiation, and MRI is generally preferred for assessment of perianal fistulas. With younger patients, I place a higher priority on doing MRI over CT due to radiation. However, in middle-aged and older patients, CT is safe and often uses lower radiation protocols than was done in the past, so it's not as big a concern. And then ultrasound is picking up steam in the United States and is readily adopted in Europe. And intestinal ultrasound has a number of features which make it desirable as a monitoring tool. It can be used as a point of care assessment to triage patients who may need endoscopic intervention or another cross-sectional imaging assessment or treatment adjustment. It's inexpensive and widely available. It's non-invasive, which is why patients show a preference for it. And in many centers, it's being adopted as a point of care monitoring option to be done in the clinic. And importantly, ultrasound has shown good correlation with mucosal healing on endoscopy. So this is something we see being increasingly adopted in US centers, though it's hopefully will be more widely available in the coming years. And there's been increasing data that's demonstrated the utility of ultrasound in disease monitoring for IBD. This is data from Germany in the TRUST study showing that significant improvements in ultrasound parameters such as bowel wall thickness can be observed within 3 months after starting therapy. So this verifies that it can be used as another non-invasive tool to monitor response to our treatments. There's also data from the recent Stardust clinical trial that's shown that ultrasound has very good correlation with findings on endoscopy, particularly in the ileum, as well as fecal calprotectin in Crohn's disease. And again, this is important because it provides us another non-invasive tool to potentially monitor response to therapies. And guidelines from the European Crohn's and Colitis Organization and the European Society for Gastrointestinal and Abdominal Radiology suggest that all newly diagnosed Crohn's disease patients should undergo small bowel assessment with an imaging modality. An endoscopic or transmural response to treatment should be assessed within 6 months of treatment initiation. And active symptoms may be assessed with enterography, ultrasound, or capsule endoscopy. And biomarkers, ultrasound, or MRI may be used as non-invasive alternatives to detecting postoperative recurrence. So imaging really has an important role in monitoring IBD. So now that we've reviewed the monitoring tools at our disposal, let's bring it back to treat to target for IBD. The International Organization for IBD published the STRIDE-2 consensus, which sets the short-term target for treatment as symptomatic response. And then the intermediate targets are normalization of C-reactive protein and calprotectin, as well as clinical remission. And then finally, the long-term targets are endoscopic healing, normalization of quality of life, and absence of disability. And while histologic healing and radiologic healing have not been named formal targets, there's a growing body of evidence for both these outcomes, and we may see them included in future iterations of the treat to target strategy. So what does this all look like when we sit down with a patient to discuss our monitoring strategy? So first, we need the baseline assessment of disease activity and severity because we want to know where we're starting to know where we're headed. And this includes benchmarking the C-reactive protein, calprotectin, and even imaging with endoscopy. Once we know the baseline, we can select the targets of treatment with our patient. And importantly, this should include not only the objective targets I've talked about, but also the quality of life and disability targets that are important to the patient. Once our targets are selected, we'll set a timeline for when to do the assessments to check in how we're doing. And if the targets aren't reached, we'll either optimize therapy or in some cases decide more time is needed if we're seeing a response. And importantly, we'll continue the reassessments until we reach the target and then fall into a more long-term maintenance monitoring plan. And again, I want to stress it's really critical that we do all of this in partnership with the patient. So here's a nice algorithm showing you what I just described, published in Gastroenterology in 2022, including the suggested timelines for assessments that I follow in my own practice. So after the baseline assessment, benchmarking biomarkers, imaging, and endoscopy, I'll do a symptom and biomarker assessment no later than 2 to 3 months after starting therapy and repeat this until the target is met. In the case where symptoms persist but biomarkers and endoscopic targets are met, it's important to investigate other non-IBD causes of symptoms. And then when patients have met all their targets, I continue to monitor in a 6 to 12-month interval with symptoms and biomarkers to keep them in a remission. So the modalities we use to treat to target will continue to evolve, but I want to leave you with a few take-home points for disease monitoring. First, it's important to implement a monitoring plan when starting treatment that incorporates symptom assessments, lab biomarkers, imaging, and endoscopic assessments. Second, it's important to collaborate with your patients on selecting the important targets in treatment and to set their clear expectations on when and how you'll expect to reach them. You want to benchmark the various lab and imaging biomarkers with endoscopic disease activity at diagnosis or prior to treatment so you know which ones are essential to monitor. And finally, you want to time your assessments so the conclusions you reach based on them are appropriate for the treatment being used. And you don't want to abandon therapies too early or keep patients on therapies too long when they aren't working. All right, so hopefully I've given you a nice overview of monitoring, and we'll talk a little bit about more of this in practice when we get into the cases. And with that, I want to turn it over to our patient advocate, Tina Aswani-Omprakash. She's really, I think, one of the leading patient advocates out there. She's really an inspiration, and we wanted to give her an opportunity to tell a little bit about her story and how her journey through her IBD, as well as how she came to be a patient advocate. So Tina, I'll turn it over to you.
Thank you so much, Dr. Cohen, and welcome everyone. That was a wonderful presentation given by Dr. Cohen. And I just want to share sort of the patient aspects and parts of my journey. My work is always dedicated to my late father, who also had Crohn's disease and passed away at a young age from colorectal cancer. So going into a little bit about my diagnosis, treatment, and surgery, I was diagnosed in January 2006, and it was a windy journey to really get a diagnosis. I had to push really hard to have a colonoscopy, citing my father's situation. I was only 21 when I was trying to push for this. I did not have symptoms, but I knew I wanted to be proactive. I didn't know much about IBD, but I knew one thing, and that was that it can hit young and it can hit hard. So I did finally get a diagnosis, and it was a diagnosis of ulcerative colitis. Now, this was very, very challenging because my family still had this concept in their mind that this was a diet disease and that I may have done this to myself. There was a lot of blame, shame, and guilt, karma at play, and some of these cultural sort of concepts and cultural stigmas that were really weighing on me at the time. I was only 22, and I thought I had done this to myself. There was a big push and a propensity towards complementary and alternative therapies, whether that was Ayurveda, naturopathy, trying different types of diets, and even Chinese medicine. And that really delayed the course of my treatment. Even when a biologic was recommended to me, it was very, very challenging for me to get on. What happens sometimes with patients in communities of color, our families are often involved. And I know this is the case with many, many communities and younger patients in general. With me, my family was heavily involved and wanted to be in the know about what was going on. They heavily stigmatized Western medicine and surgery. My father was left on prednisone for 15 years. Really hated his ostomy, but this was several years after my father had passed away, and I think that had sort of left a dent in their minds too. So it was a lot, that I was sort of up against, and it was very, very challenging for me to advocate for myself and do so in a way that, could proactively get me the treatment that I needed. I did eventually have emergency surgery on the 4th of July in 2008, had my colon removed, and had an ostomy placed, and my surgeon wanted me to move towards a J pouch. This was very, very challenging for me. I was told by my family that I wouldn't get married with an ostomy and that I should go for a J pouch. I was very comfortable with the ostomy. I'd gained a lot of weight and sort of felt like myself again and was able to live my life again. I was very hesitant to move towards a J pouch. But I did. After about 8 months, I had the 3-stage surgery and actually needed 4 total surgeries at that point due to complications I had from delays in getting to that surgery process. There was a lot of psychosocial challenges I was facing during this time too. I was working on Wall Street and I had to take a leave of absence. And it was very, very hard because many of my friends were in banking, consulting, medicine, and I sort of felt like I was falling behind in a lot of ways. I had a very successful career till that point. And, as I went along, having surgery after surgery, spending almost every holiday in the hospital with C. diff or some kind of complication, it was very, very challenging. While I was very happy to see my friends move forward in life, it was also very hard for me to see, people having children, getting married, getting promotions, because I felt like I was just sort of languishing in the hospital. So these were all challenges I was facing in my 20s while having multiple surgeries. Now, these 3 images really illustrate kind of what I went through over the next several years. So in 2008, I had my first surgery, and in 2009, I had my takedown surgery. Before even my takedown, I developed pouchitis, so inflammation of the J pouch. This led down a long, windy road of being on chronic antibiotic use, and I became sort of resistant to a few of them, then moved to biologics, especially when there was this sort of question mark as to whether this was Crohn's or not. My physician saw granulomas and started suspecting Crohn's. Once I developed my first rectovaginal fistula in late 2010, we started to call this Crohn's disease. And I really needed to get back on a biologic. At the time, infliximab and adalimumab were all that was available. Upon reinduction of infliximab, I actually developed anaphylactic shock. I also developed antibodies to adalimumab. There were a lot of discussions around what should be my next steps because there weren't many drug options left for me at the time. So we did decide on diversion, which means that my J pouch was disconnected and I was given a diverting loop ileostomy again to try to calm down the fistula symptoms. I had multiple fistulae at this point. And I developed more over time. Even when vedolizumab came out in 2014, I continued to develop more rectovaginal perianal fistulae and abscesses. So at this time, in very late 2014, we decided I needed a J pouch excision. I went ahead with that. That was unfortunately not done correctly. So I went through 7 more surgeries to correct that. So this is what you're seeing. I had an opinion at Cleveland Clinic and a third opinion at Mayo Clinic. Mayo Clinic did some of my corrective surgeries. Cleveland did as well. And I had to have a wound vac placed, and you'll see me kind of sitting lopsided on a park swing here outside of Mayo Clinic. It's me trying to recover from massive surgery, a lot of trauma from having a wound vac placed on the side of my bottom, having a wound this large, trying to remove a 9-centimeter abscess that was multiloculated in my pelvis, and that had a fistula headed for my spine. So I was really going through a lot during this time. This was 2015. After all of that, I was put on Stelara, ustekinumab rather, and at that time I was told that there was another fistula, a hole in my vaginal wall, and that even without the rectum there, my disease was trying to continue. So I was put on ustekinumab at that time prior to FDA approval, and within 6 months or so, I was in remission. So the last photo you're seeing is me in early 2016. So just about 8 years ago, Valentine's Day, 8 years ago, and me trying to get back on my feet, trying to walk again normally after having, sciatica and pelvic floor dysfunction from that wound vac placement and not being able to sit properly. Coming out of this, I decided I really wanted to make a difference. I had been through so much. I thought my knowledge could perhaps help other patients. But first I had to reinvent myself. I really did not know what my personality was, what my identity was after everything I had gone through. And, this had really taken apart my marriage and many of my friendships. I really had to find myself all over again. I went through a lot of therapy, a lot of support groups. I even started running support groups, and it was really the Crohn's and Colitis Foundation support, in launching me and helping me get support groups started, whether that was the women's support group, caregiver, teen support group. And then they launched me as their honored hero at their Take Steps walk in 2018. And since then, I've actually been publicly advocating. It was what I call social suicide to start advocating in my community. In the South Asian community, this is a very, very, very stigmatized condition, and it brings a lot of shame upon your family if you become public about something like this. I chose to do so because I thought it was extremely important for me to heal, one, and two, for me to support a community that I knew existed and that was probably suffering in shame and in silence. And when I launched my blog, Own Your Crohn's, I didn't realize what I was getting myself into, but it was like opening a Pandora's box. There were many, many, many people starting to message me from around the world saying that they're suffering from many of the cultural stigmas that I was talking about. This is just an overview of some of the work that I've done over the years. One of my main articles, Real Talk About Fistulae, which you'll see in the middle, I think to date is probably the most read article. This was done in January 2019, where I was talking about how harrowing the effect of fistulae have been. And to date, a lot of patients still reach out about this because it was one of those topics back then was not being discussed at all. So this has really been the impact of the work, and it is very, very helpful to know and very validating to know that patients around the world can feel more comfortable talking about some of these more stigmatized subjects. So really rounding out, my journey, I've had over 20 surgeries. How did I come into remission? How did I maintain that remission? And have I had flare-ups since? So from 2016 to 2024 today, I think what a lot of what we've done is do a lot of the things that Dr. Cohen was describing, testing drug levels, antibody levels. At that time, it was not known whether or not you can develop antibodies to use ustekinumab. So I was put on 6MP side by side just in case. Then I was pulled off when it didn't appear that I would be developing antibodies to ustekinumab. I was having routine ileoscopies through my stoma to really take a look at whether the ustekinumab was working. And we did do cross-sectional imaging, mostly MR enterographies, to look for more fistulae, which had largely healed. We did have to, at one point when I started showing disease activity again, in about 12 centimeters of the small intestine, we did reinduce the ustekinumab as part of the POWER study, and we changed the dosing and the frequency to really shut down that inflammation again. So that was sort of the benefit of that proactive approach. It was putting me back in remission again in 2019. We did add back a secondary agent just 2 years ago, the 6MP, because I was diagnosed with autoimmune hepatitis and Sjogren's disease. So these are some things that we realized, seeing that my liver enzymes were off, and I started seeing a hepatologist to try to figure out what was going on. And that's how that happened. We worked on optimizing diet and nutrition, considered my ethnic diet, and we also talked about enteral nutrition, parenteral nutrition, and I've had a fair amount of TPN with my surgical journey throughout. And just note that with optimizing diet and nutrition, that was done after we optimized the therapy to try to space things out and really understand what was working. I was also encouraged to see the GI psychologist, social worker throughout to try to normalize that mental health support, and of course, attend support groups throughout. A few things that I would suggest considering in general for patients is asking patients about some of these more sensitive subjects like marriage, intimacy, and pregnancy, what our hopes and goals are. Also consider involving spouses and parents in discussions who may not understand what their family member might be going through. I know that would have been key even in my journey, and still is key in my journey. Also considering in especially different communities and in sexual and gender minorities, cultural sensitivity, and talking to folks about their goals and what really is important to them to make the most appropriate shared decisions. With that, I'd just like to wrap up. Thank you so much for having me share my patient experience on this, and I hope it can help you all with sort of deciding your next steps as patients too.
Thank you, Tina. That is really an inspirational story and really amazing what you've gone through and persevered through, and now how you're giving back to really the community, I think is unbelievable. And we appreciate you spending the time with us today to get your perspective. So with that, we're going to turn it over to Dr. Alomari. So we're thankful to have Dr. Reeder and Dr. Nasir, my colleagues here at Cleveland Clinic, along with Tina, to get their thoughts on the case. So Dr. Alomari, take it away.
Hello, everyone. We got to get started. Next slide, please. So our first patient is a 20-year-old female patient with history of ileocolonic Crohn's disease and rheumatoid arthritis. She was diagnosed with Crohn's disease at the age of 18 when she presented with watery diarrhea and abdominal pain. The following year, she was diagnosed with rheumatoid arthritis involving both of her hands. Her very initial colonoscopy showed inflammation in the cecum, the ileocecal valve, where the terminal ileum meets the cecum, essentially, without a stricture, and also going into the terminal ileum. And the pathology confirmed chronic inflammatory changes. She was initially treated with a course of topical steroids, specifically budesonide, with clinical improvement, and was really hesitant to start biologic therapy due to fear of adverse effects. However, instead, she followed a diet-focused approach. Next slide, please. So 2 years later, she comes while she's off therapy with worsening watery diarrhea up to 6 bowel movements a day, right lower abdominal pain, and occasional nausea and vomiting. And these are the pictures from her colonoscopy the same year, 2020. As you can appreciate, there is inflammation, ulceration at the ileocecal valve on the right side of the screen, and also in the cecum and also in the terminal ileum. And to put that into context, we typically use a scoring system for patients to describe endoscopic findings in patients with Crohn's disease. Next slide, please. So this scoring system called the Simplified Endoscopic Score for Crohn's Disease, for short SESCD, and really looks at 4 different elements, which are the presence and size of ulcers, extent of ulcerated surface, extent of affected surface or inflamed surface, and presence of narrowing. And those elements are scored from 0 to 3 in the 5 segments that we typically evaluate in our colonoscopies. And putting that into context, our patient had an SESCD of 9, which truly fits in the moderate activity category. Next slide, please. So this brings us to the first discussion points.
All right. So thank you, Dr. Alomari. So Dr. Nasir, so you have at this point, you see what the endoscopy looks like. Patient is symptomatic. They haven't been on therapy. Is there anything else you need to stage their disease at this point?
So I think there come a point of the role of biomarker monitoring. So at this point, we should get her blood test for CRP and the stool test for fecal calprotectin to see what are the levels of inflammation in her blood and stool. We can also get like imaging studies of her bowel, like MRE or CT intrography, to see if she has more widespread disease involving her small intestines. And like we discussed before, as a point of care ultrasound is also an option.
Definitely in centers that have it. Dr. Reeder, anything else you would add to that point? And then how would you approach therapeutic options for this type of patient?
Yeah, so I agree with Dr. Nasir, and I think one critical point is cross-sectional imaging and at diagnosis to assess for complications, because we are not able to do that fully with endoscopy only. And then if the patient has any upper GI symptoms, one may consider an upper endoscopy. I personally only do that if the patient has upper GI symptoms, but just to rule out any upper GI involvement. In terms of the biomarkers, I completely agree with everything Dr. Nasir said. Therapeutic options in this case, so the patient initially was concerned about biologic therapy, and which suggests that biologic therapy has been brought up early on, which I would have done also. And therapeutic options here are determined by the disease location, by the disease severity, prognosis, and then in this case also concomitant immune-mediated disease, rheumatoid arthritis. So we have 15 centimeter terminal ileal disease, which overall I think warrants early biologic therapy with deep ulcers on endoscopy. And rheumatoid arthritis. And so I would choose a medication that would probably cover both entities. And anti-TNF is very high on the list. This could be infliximab, or adalimumab as first choices, and I usually combine with an immunomodulator, at least in the first year of therapy, and that could be methotrexate or azathioprine. And in young females, I would probably choose azathioprine. Anti-IL-12/23 or anti-IL-23 in general would be options in this patient, wouldn't it be for the rheumatoid arthritis? Because trials with anti-IL-12/23 or 23 have been negative in rheumatoid arthritis. So I think anti-TNF would be higher on the list. And then we have JAK inhibitors that could cover both. Then the United States system would become an option after an anti-TNF failure, but not early on. Vedolizumab is a gut-selective medication, and the TNF-naive luminal Crohn's disease in general is an option, would not be highest on the list, wouldn't work for rheumatoid arthritis. So I would probably start the patient on an anti-TNF in combination with immunomodulator.
Great. And Dr. Nasir, in the situation, let's say we're starting the patient on the anti-TNF, as Dr. Reeder suggested, how do you monitor the patient? So what are the expectations you set when you start therapy about what you're going to check in when?
So when I start my patient on anti-TNF therapy, first of all, there should be like symptomatic improvement. So like on our follow-up visit, there should be like improvement in their diarrhea or abdominal pain or bloating sensation. And then at baseline, we get like CRP and fecal calprotectin, which is the blood and stool markers of inflammation. At subsequent follow-up, we should we monitor those labs to see if there is any improvement in their lab biomarkers or not, including with the symptoms.
What's the time point you tell the patient that you're going to repeat the labs and do the symptom assessment?
So usually do like a repeat blood test and stool test in 3 months and colonoscopy in 6 to 12 months after initiating a new medical therapy.
Yeah, and I generally follow the same practice. I would say I'll usually, when I start a new therapy, sometimes I'll do a visit either with myself or my advanced practice provider after a month, just to make sure that we're getting some early symptom response along with the treat to target, but then generally check the biomarkers again in the 2 to 3 month range, as well as the following up the colonoscopy to confirm healing at the 6 month mark. And this prompt, this patient, and this is common, I think, where patients have concerns about all the different testing that we tell them to do, and it can be very overwhelming, especially a patient who maybe had some concerns about the therapies in the first place, and maybe a newly diagnosed patient. So Tina, I'm wondering what recommendations you have to us as the providers about how we talk to patients about all the different things we want to do, because sometimes I feel like I'm throwing the kitchen sink out there, but maybe that's not what the patient wants.
That's a great question, Dr. Cohen. I think for me, what's been important is getting a handle on the disease. And I think it's important to explain to the patient, the sooner we get this under control and the more proactive we are with this, the more quickly we can shut down the inflammation and get you back on the road to living your life, working, studying, what have you. But at this time, we may need to do the imaging, we may need to do the colonoscopy. And something I've been doing is, for instance, I just recently had an MRE to keep tabs on my disease. And I did a weekday evening. So after work, I've done weekends. If that's available to you, definitely suggest that as doctors to patients, that this could be done in a way that's more flexible. Same thing with blood tests. I have those like every 2-3 months to check my inflammatory markers. And I instead of going into the hospital every time and taking time away from work, I'm asking for a prescription, whether it's to like LabCorp request or something that's a little closer to me, so that I could just step out for 15 minutes and get this done. So I think there's ways around this, and I think we just have to be a little bit creative about how we do this. And of course, with intestinal ultrasound now, if that's an option, it is important for patients to know about that and maybe be able to fit that in if that's a little less time consuming and requires less preparation for it. Because I know MREs and colonoscopies tend to be more bowel prep heavy. So these are all things to consider for patients and for patients to know about.
I think really great points, and it just highlights why we have to have discussions with our patients to understand like what's important to them and come up with a plan that's going to work for them. And there's another really great point in the chat about being accessible to the patients after we do all this testing to really explain the results, because if we order all this stuff and then never communicate, you know, what the results are and what the meaning is of that, it feels like a waste of time on their part. So I think really, really great point. You can go to the next slide. All right, so Dr. Alomari.
So the patient was started on adalimumab induction followed by every 2 weeks maintenance in March of 2021. And she comes to the clinic 3 months later, reporting remarkable improvement in both gastrointestinal and joint symptoms. Now she's down to 1 to 2 form bowel movements a day without abdominal pain. Her inflammatory biomarkers both normalized, and calprotectin was 45 and CRP was within normal range. Colonoscopy 9 months into therapy showed only mild inflammation limited to the ileocecal valve area with an aggregate SCSCD score of 2, which corresponds to endoscopic remission. So how to monitor disease activity from this point?
So Dr. Reeder, how do you feel about this response, and what would you tell the patient about what the plan is from here?
Yeah, so I would be actually quite happy with this response. So an SCSCD of 2 means the patient is ulcer-free, which in someone with the endoscopic picture the Dr. Alomari showed earlier, I think is a significant success. And so I'm happy with this result. I don't strive for perfection, and if the patient has a few erosions and erythema, I'm actually quite comfortable. I assume the imaging did not show any complications early on, and in a scenario like this, I would probably monitor the patients every 3 months with the CRP and a fecal calprotectin. One information that would be interesting is what Dr. Nasir mentioned earlier. What was the baseline fecal calprotectin when the disease, the SCSCD was higher, and did the patient ever mount a CRP response? Because a normal CRP, like Dr. Cohen mentioned in his talk, maybe due to the fact that the patient cannot mount a response. And in small bowel disease, like this patient predominantly has, a low fecal calprotectin may not necessarily mean that there's no active disease. So I would link the two together, and then with the improvement, if both of these markers improve, I could use them for tracking as we go along. I would meet the patient every 3 months in clinic, track on biomarkers if they are appropriate for that and were elevated initially. And then probably would consider, if the patient feels good, the biomarkers stay low, I would probably consider doing another colonoscopy at 1 year after the prior one. And if that looks stable, and the patient remains stable, I would probably feel comfortable potentially spacing out the endoscopies in the future.
I think again, well taken points, and this is where those new guidelines that I mentioned, utilizing the biomarkers when you have confirmed that mucosal healing, that if the patient and the provider feel comfortable stretching out the interval, you can really use the symptoms and the biomarkers to help you do that comfortably. You can go to the next slide.
The patient comes the following year to a clinic visit and sharing with us the good news. Now she's 5 weeks pregnant, still taking adalimumab every 2 weeks. However, she lately had some worsening GI symptoms in the form of diarrhea, up to 4 bowel movements a day, with some mild lower abdominal pain. Her nutrition intake is good and weight has been stable. We did some basic blood work and stool tests. The blood work showed iron deficiency anemia with ferritin of 20 and hemoglobin of 9.8. Her C-reactive protein was elevated at 12. However, her folate and vitamin B12 and albumin were within range. The stool studies were negative for infectious workup. However, her fecal calprotectin was elevated at 600. Next slide, please. So this will be our second discussion points.
So Dr. Nasir, how does pregnancy impact your strategy with monitoring patients assessing symptoms?
So pregnancy is always a tricky situation, and then we have to be very mindful of what are we offering to our patients because of the risk to the baby and the mom. The role of biomarker monitoring, including CRP and calprotectin, is very important. We can offer colonoscopy to our patient, but in emergency situations, especially like in second trimester, maybe more suitable to do it as compared to first or third trimester when the risk of complication is high.
And what about interpretation of the different biomarkers in the pregnant patient?
So the CRP, this patient clearly has definitely very high CRP, which is elevated from baseline, and then calprotectin is very high. So definitely she is in a flare. So I would stick with the same level, like calprotectin less than 150 and CRP less than 5. Depends on the level of different labs.
And I think one thing to point out is that CRP during pregnancy can be elevated. So CRP may give you a false sense, but that's where having the calprotectin paired with it, and you see that elevated, I think that can be helpful. Dr. Reeder, any concerns around imaging choices during pregnancy? How do you approach that?
Yeah, and I really liked Dr. Cohen, your comment about the CRP in particular. Actually, towards the end of pregnancy, CRP can be elevated without any active disease, and fecal calprotectin remains an active marker and remains an accurate marker during pregnancy. So in terms of imaging, we would like to avoid CT because of radiation. We avoid particularly early in pregnancy MR with contrast because of the gadolinium. I think intestinal ultrasound is a very good choice in patients like this. It may be difficult in later pregnancy, third trimester. Ultrasounds tend to be harder to do from the bowel, but I think this would be a very good choice for pregnant patients and a patient like this that's 5-week pregnant. So if you have ultrasound available, that would probably be my first choice.
I agree, and I think again, key here is really talking with the patient, because there's going to be potential risks in some of the monitoring strategies we may take on, and we have to work collaboratively with their OBGYNs as well if we're dealing with a patient with potential flare.
But one other thing is to mention, I think that could be relevant here is drug monitoring for adalimumab, because patient is on adalimumab. So in pregnant patients, probably not at 5 weeks pregnancy, but later on the distribution volume changes, and this may affect drug levels during pregnancy and TNF drug levels during pregnancy. And so if a patient like this has a flare, I do think it's worth checking drug levels early on, even though having said that 5 weeks is not a big factor, the distribution volume changes, but it could be, I would have a low threshold also getting drug levels in a patient like this.
Agree, a great point. Well, time flies when you're having fun, and we're already at 7 o'clock. And I think really this has been a fantastic session. I'm sure we could probably go on for another hour, but people want to get to their families for dinner, so we'll respect time on the East Coast. But if you could pull up the closing slides, I just want to thank our speakers, Tina with her amazing story as a patient advocate, and also her perspectives, I think really add a lot to how we can elevate our patient care. Dr. Reeder, Dr. Nasir, and Dr. Alomari, thank you for putting together the case. And our next program is you can go to the previous slide. Our next program is going to be on May 7th, where we're going to talk about discussing risks of advanced therapies with patients, and we're going to have a fantastic talk from our world-renowned pharmacist, Dr. Shubha Bhatt, And we'll have guest faculty with Dr. Ashkar and Dr. Ruggiero as well. And our patient advocate will be Galen Henderson, who's also another fantastic patient advocate. I can't wait to hear her story as well. You can go to the next slide. So we want to thank again our sponsors for making this all possible: AbbVie, Janssen Biotech, and Takeda Pharmaceuticals. And as always, we have plenty of live webcasts available to you, not just in IBD, but in all different sorts of digestive disorders. And look forward to our next patient and provider series, IBD Primetime, EIM Live, and all of the various offerings we have. So thanks again, everybody. Hope you enjoyed the session and have a good night.